So I'm coming from Pakistan, Aga Khan University, and this is an image I took from the plane of my university. Uh, so that's pretty cool, isn't it? Um, uh, so um, so uh, we do not have a good understanding of brain tumors in Pakistan, and that's one of the LMIC. So this is where Pakistan is. And if you look at the locale data, we don't have any data for Pakistan, for Afghanistan, and then most of the LMICs over here. And we wanted to understand the incidence of brain tumor. So there was some data that was presented by Pakistan Atomic Energy Commission, which was not a good data. It was very crude data. So what I did was develop a Pakistan brain tumor consortium, and about 80% of all the institutions across the country took part in it. This was a retrospective study uh, done in 2019. Didn't want to do it to 2020 because that's when the COVID had hit, and things might have changed. So restricted myself to 2019. It was we chose all the high volume and all those institutions that had a residency program in neurosurgery, so that to make sure that we are collecting reliable data from across the country. And this was done on the society that I had made, Pakistan Society of Neuro-Oncology, and the Pakistan Academy of Neurological Surgery that I had formed. So this was published in the Journal of Pakistan Medical Association. I know from your perspective, you would prefer it to be published in maybe your Journal of Metastasis, or maybe a Journal of Neuro-Oncology or Neuro-Oncology, but I wanted to publish this whole thing in a supplement. That's why I chose this one. So what we found was that the data that we collected, it was surprising somewhat that the total number of surgical patients that went through neurosurgery for brain tumors was only 2,750. And the histopathology of the tumors was somewhat different than what we see in North America and in other parts of the world. The most interesting thing that I found was that it was the metastasis was only 2.7%. If we expect that about 30% of tumors that are seen by neurosurgeons in the neurosurgical service is 30%. And in post-mortem studies, we know that the metastases are found in about 80% of all the brain tumors seen in autopsy. About 80% are metastases. So that was extremely low incidence that we found in our population. Now, we do know that there is a difference in histology subtypes. For example, these papers have been published in the past where they compared Georgia with Zurich and things like that. Uh, but there was some gap in our management of brain tumors, and that might be leading to it. So, for example, our lower class, which is blue collar workers, is about 70% or so, but only 48% underwent treatment for brain tumors, and that there was, uh, disparity between our population and those that sought treatment for brain tumors. And then there was difference in our age also. So if you look at this CBA trust data and this PBTES is my data, that's Pakistan Brain Tumor Epidemiological Study. So you see that the peak is in CBA trust data is coming to over here in the midlife, whereas the peak that is happening in the PBTES data was actually much earlier. Now there's a difference in population of United States and Pakistan, because there's much younger population, and whereas in USA the older population sort of has started to predominate, but still that does not explain this shift in curve. In the metastatic tumor, the most common tumors were breast, and then lung, and then lymphoma, which is different than what we see globally, where the lung, breast, and melanoma are the most common ones. So there's a difference in what kind of tumors that we are seeing as metastasizing to the brain. We did have melanoma here, and and some other tumors. Colon was not so high. Um, and this also shows the international epidemiology of brain metastases. Uh, Patrick Penn's paper showing lung as the most common one, and melanoma was pretty high. But in our cases, the melanoma was very low. So, what is the reason that we have this kind of a difference? There can be three reasons. One is that the biology is different, maybe. That's a possibility. Patients do not survive enough to develop brain metastasis. That's another possibility, because they don't get adequate care and they die early, and or the family gives up, because remember, the resources are very limited in this part of the world of personal resources, and there's a high incidence of catastrophic medical expenses, and patients being pushed down below the poverty line. So the family gives up and does not get treated first. um, Further dissecting the data on metastasis, we found that, again, if you notice that the age of diagnosis in years is, I don't know if you would call it really bimodal or not, but this still peaks around age of 50 or so on average, which is a little higher. And if one looks at the tumor present in different part of the lobes, 56% is in the frontal lobe, which and 5% in cerebellar lobe, which is slightly different from the international data, but still not too different. Now, so why do we have these kind of problems? The difference in incidence, there might be some thoughts on maybe the way the brain tumor is managed in this part of the world is different. So if you look at the distance travel for brain tumor in a low-income country, this is about 30 to 40 kilometers distance traveled, whereas in high-income countries, it's about 10 kilometers, less than 10 kilometers, right? Um, in my study, what I found that about 60% of patients had to travel more than 50 kilometers. So 41% patients travel less than 50 kilometers, 60% patients travel more than 50 kilometers. And out of those, or overall, 20% of patients had to travel more than 500 kilometers. So that traveling distance might be the reason that patients, those who develop metastasis, then they are not taken back to their centers. There's a lot, and because of that, there's a lot of loss to follow up about uh, patients that did not follow up is about 40%, and that's a pretty high number. And then there are some other biases as well that I'm still studying on that. So, for example, there's a gender distribution that we found more male than female. And although, yeah, males do have little more brain tumors, except for meningioma, for example. But then, if you look at the ratio of PBTES and CB trust, uh, anything that's more than one, it shows there's a gender bias. And all of them had a ratio of more than one. So, so if you look at over here, even in meningiomas, it seemed as if there was more gender bias than we would expect. So this might be the reason that first socioeconomic status, distance, and gender, that might be um, the reason. So we don't know about most of the patients what happened to them once they are taken care of initially. And here's an example that in this data, if you try to figure out that once the patient were treated initially by surgery, did they get radiation therapy or chemotherapy? Yes, no, which is fine. I mean, there are some tumors that will not receive radiation therapy or chemotherapy. But then, as much as 55 to 64% of patients, we have no idea whether they received radiation or chemotherapy or not. So that's a big gap. And that's not only true for all the tumors. Even if you look at for the radiotherapy for glioma and look at the grade 4 glioma, the not available data, we don't know what happened to these patients, is as high as 55% over here. And then grade 4 glioma, about the no over here, about 14% of patients did not get radiation therapy. So there's a big gap in the management of brain tumors. Um, and same applies to chemotherapy. Now, one of the reasons for that is obviously, as I mentioned, distance and other biases, and then obviously the per capita income that we have in Pakistan is pretty low, $1,500, and with all that that we see over here, we still try to, you know, push a square peg in a round hole. You know, people like me who have been trained in USA and come back and we try to do things based on those standards. That doesn't work very well. We I can't use 5 ALA, for example, over here, because the total cost of craniotomy is $5,000. Excuse me. And 5 ALA, it's about $1,200 a while. So I can't use that. I have to just use my own techniques, and fluorescein doesn't help that much. The this gliadel I used to use very often in when I used to practice in Michigan, but this is like $11,000 compared to the $5,000 price of craniotomy. Excuse me. so so the cost and the resource limitation is the reason. Also, we don't have enough MRIs. And if you look at the per million population MRI, highest is in Japan, about 55, excuse me, per million. We fall pretty low in less than point 0.2 in per million population in terms of MRI. And that's where this concept of using a mobile MRI steps in. And I have started to do that. And we have published quite a few papers using mobile MRI. And they actually give pretty good results over here. If you look at the 1.5 Tesla and the ultra low field MRI, preoperatively, immediately postoperative, and delayed postoperative, the data is reasonably comparable to give us an idea what where and the tumors are. We don't need to have that much detail in there. I'm also working on the policy recommendations for early detection of brain tumors, and and in our analysis, the mobile low field MRI are emerging as one of the very important. Excuse me. So what I'm doing now is after the PB test, I'm doing the prospective data collection, looking at that health economics and everything. And I guess what I can say is that know thyself, know thy enemy, a thousand battles, a thousand victories. That's when we would know things more. And this is the team that has worked on these things. So that's all I have to share.